Hold on, everybody. Let me, I'm not sure why it's kicking other people out of the link. Okay, hold on a sec. Let me send a new link. So stand by. So I have, Becca. Okay, hold on a sec. Let me. Hold on a sec. Let me see what is going on. Is everybody here? I'm not sure what's going, why it's
Hello. Yes, we have been finding it difficult to get in.
yeah, because I don't know why it's for some reason. All right, hold on a second. Let me just see who's here. So Patricia. So Piva is here, and Dorothy, and Ashaba, and Ikalu, Cornelius.
Yeah. I think we are all here.
Okay, I think everybody is here for now. Is everybody here for now? Yes.
Yes,
We're good?
that's
Yes.
what.
Yeah.
All right. So I'm just going to monitor quickly, but okay. A little bit, running a little bit, but let's get to work. So let me start with introductions, and we start with Ms. Bennett, Ms. Kendall Bennett, and kind of get into the session. Ms. Bennett.
Hi, I'm so happy to be here. I'm so excited to hear about your work and everything. My name is Kendall Bennett. I work at the Old Colony YMCA in Massachusetts. My background is that I got my master's degree in public health biostatistics from the University of Massachusetts. And so I do most of my work in program evaluation. So I know lots about a lot of programs, but I'm certainly not the expert in any one of them. So I'm really excited to be able to present the work that the people that I work with do. And it's so great to meet you.
Wonderful. And so do you have a presentation to share? Because I enabled the screen.
Yeah, I do.
All right, so let's start with you sharing your presentation.
Okay, sounds great. 1 second. All right, can you see it?
Yes.
Thank you. Okay, so I basically just made a presentation that was really a lot of pictures that reminded me of things I wanted to talk about rather than words on the screen, because, you know, well, it's just better to have a conversation, I think. So I've been at the Y for 5 years. We are a YMCA, so we have a gym and, you know, we have a pool and we have all that sort of thing. We have 7 different gyms, but we also have, you know, many different social service programs throughout the state of Massachusetts. So we really are in the preventative portion of that primary prevention in public health. We're really in the very early stages. of being able to prevent poor health outcomes. So we really focus a lot on the social determinants of health. So we think about ways that we can help keep people healthy, starting with little kids, going all the way up to senior citizens, and the ways that we can support people to achieve their fullest potential, whether that be physically or through their education, advocating for social justice, any way that we can help the community to be healthy. And we really see that as the whole of people's environments. So just some of the really basic, like sort of the most preventative health programs that we have a lot to do with education and physical safety. So this program on the top right, where we see our 3 little graduates in their orange shirts, that's one of our summer learning loss programs. So here we have, school from September to June, and then we have the whole summer off. And so if kids don't have somewhere to go, like camp or a childcare or family that can be home with them, they lose oftentimes several months worth of education over the summer, and they actually regress and lose some of what they gained in the previous school year. So we work with young people, and we do preventative education so that they can go into the next school year in a good place, so that they can learn more. This on the bottom right with our little guy with the mask, we have some of our remote learning programs that we've done with school being closed for the entire last year because of COVID. Many of our little ones were at home by themselves while their parents were essential workers and had to be at work. So we set up remote learning programs so that little ones could come do their schooling or their online school with us, so that we could help make sure that their education stays on track, because we know that if people have a good education, they're more likely to have a job that can pay all their bills in the future. And that's really important to keeping them healthy in the long run. On the bottom left here, we see a program that we have called Youthbuild, and that's for young people that have dropped out of high school, and they want to get their sort of what we call a high set here, which is your grade equivalency, your GED, so something that says you've done the equivalent of completing high school, an education certificate. So they complete that program with us, and they also learn how to do vital skills like construction work or certified nursing, and they get certified in everything that they need so that they can again increase their economic earning potential, so that they can provide for themselves and for their families another way. That would be really important to keeping people healthy. And on the top left, violence is a big concern. Always for us. Gun violence is higher than it's ever been in our area. So we have this program called Street Outreach, which recruits, it's a group of people who have former gang experience or involvement, and they actually recruit young people to be in their program. They mentor them and they help coach them and try to get them out of their gang, and they help to get them jobs, to get them housing placements, to support their families, so that they can decrease violence in our community. They are involved with the police department. So it's a progressive program where we have social workers and clinicians that are able to work in the community to support the police rather than just having a police first response. So it's a program that's been going on for a while, and it's something that we're really proud of. Because it really does help reduce violence, and it employs people who have lived experience, which is really important as well. Moving on to some more traditional health focused ideas is one of the things that we do around healthy eating is we help set up community gardens. So we'll help with the infrastructure, the fences, the land, getting the garden set up, and we'll recruit volunteers that will help put together and maintain a community garden. Any extra food that they grow is donated, and so this is one of our gardens that we've had for a while now, and it's now completely run by volunteers. So after we got it set up, we were able to to give that along to the volunteers so they sort of maintain it every single year. And although we've had far too much rain this year to grow anything meaningful, we are doing our best. Obviously, when you think of a YMCA, if you're familiar with a YMCA, I know we're all over the globe, you probably think of the gyms. So on the left-hand side here, we have a group of people that are just working out together, which is, you know, sort of our traditional Y motto. Down on the bottom here, we have a little one that's learning how to swim, and that's our program for young people with developmental disabilities. A lot of the children are on the autism spectrum, and so we have specific programs for them in order to help them stay healthy, because there's really very few programs or supports in our area to help young people, especially things that are free. And this program is free to help young people that have developmental disabilities. And then on the right-hand side here is a program that we have called Waterwise. And so what we try to do is we try to get every second grader in our community to come down to the pool for a day. So they take a field trip from school with their teachers, and they learn the core principles of drowning prevention. We've had more drownings this year in Massachusetts than we have in decades. It's been a really difficult summer for water safety. And so they learn sort of the key things that they need to know to stay safe around water. I mean, we certainly can't teach every kid how to swim in a day, but we can teach them, you know, the top 3 principles of, you know, make sure you ask before you go in the water, or, you know, some of the other things. So we're really trying to do that here, especially whereas we do have a lot of bodies of water outside. We have lakes and ponds and reservoirs in the ocean. But we don't always have a lot of supports to be able to teach young people how to swim. It's not something that's covered in school. There really is no program for people to go to. So we're really trying to expand that program and prevent more drownings in our communities. And then finally, almost finally, we have a number of programs that help with chronic disease prevention. And so prior to the coronavirus, everything we ever focused on was chronic disease prevention, because we have so few really terrible infectious diseases in our area that you know, all we can focus on is preventing those obesity related illnesses. We have the diabetes prevention program, which is it's a weight loss and lifestyle management program for people that are diagnosed with pre-diabetes. And it can prevent diabetes in 57 to 75% of people that complete the program, depending on what their age is when they start the program. On the left-hand side here is a program that we run called Brockton Knocks Down Diabetes. And so we offer, for a week every summer, we offer free diabetes education classes around the city. So we try to go to places that are extremely convenient. Brockton is a pretty small city that we have. There's a lot of poverty. And so we try to go to the housing authorities, the Council on Aging, places where people can walk to. We offer programs in many languages. We have an extremely large Cape Verdean population, an extremely large Haitian population here. So it's really important that we're able to meet people in a variety of languages. And so that's something that's always really important to us, just to make sure that people who often can't get the care they need in our healthcare system, because we could be doing a lot better there as well, that we can provide education whenever possible, especially to people who are non-English speakers or English is their second or third language. On the bottom left here, we have a program called Live Strong at the Y, which is a program for people with cancer. And so we help people with cancer through education and physical activity to help them through their treatments and to get back into shape after their treatments, hopefully. And so that's just a program that's offered at Wise all over the country, and I'm actually sure all over the globe. And on the bottom right here, we have a blood pressure self-monitoring program. Again, obesity-related illness has historically been one of the biggest things that we focus on, just as a very preventative healthcare type of public health agency. So we have a program where people come and they check in with us on their blood pressure every week. And we try to run that throughout the entire year. Obviously, everything changed for us. We had really significant COVID-19. We had really significant COVID-19 impacts here in Massachusetts. As a pretty small place, we were having thousands of cases every day. It was really, really taxing on our healthcare system. We were wholly unprepared for a situation like this. We don't deal with infectious disease very often, and it overwhelmed us pretty significantly. So what we could do as the YMCA is we had to open emergency childcare sites because all of our businesses were ordered to be closed, including places that watched children. However, people who worked in grocery stores, healthcare professionals, all had to go to work. And so we were able to open emergency childcare sites where people could drop their children off for free to be watched while they were doing their emergency work. So that was a really great opportunity for us to be able to provide for the healthcare system. On the top left and the bottom left is some of our food insecurity responses. We have significant hunger issues in some of our communities, and we did before the pandemic, and we much more do now, and we will for a very long time. And so we're able to partner with several organizations. One of the things that happens in our state is low income places, students are able to get free breakfast and free lunch at school. But when kids were at home, they couldn't easily get their free breakfast and their free lunch. And so many kids were going hungry. And so we're able to, right outside my office in downtown Brockton, this big truck that's on the top left there pulls up twice a week and opens the back, and people can just run by, no questions asked, and grab a box of really great food and take it home. We also have a program called Fair Foods, which is the picture on the bottom left, where people can get a $2 bag of food, which is really, really cheap. And it's all food that's very good, but has technically expired at the store. But the food is fantastic. And so those programs are really exploding, and it's a new thing for us to work on, being able to give out food to people, but it's so, so important. And so we're really happy to be able to support food insecurity. I think we feed over 5,000 meals a week, and that was before the pandemic. So I think the number is much, much higher now. That is the gist of all of sort of an overview of many of our programs. I'm so thrilled to hear what you all are working on and studying. So if you have any questions, feel free to let me know, but I'm really eager to hear from you as well.
All right, thank you, Ms. Kendall. That was wonderful. Fellows, let me transition to your presentation. And you'll be able, so let me find your presentation. I think you sent it to me. And do you want me to share, or do you want to share from your end?
I think I'll share from my end.
Okay, so Cornelius, you're going to share from your end?
Yeah.
Go ahead, go for it.
All right.
And then after your presentation, we'll go into a discussion session. So take your 15 minutes.
I hope you can see the slide. All right, good. All right. So hi everyone. We will be talking about public health programs, gaps and disparities. As much as possible, we try to base a lot of the information on the healthcare aspect. Public health is really broad. There's a lot of information, but we tried a bit more possible because in the group we had a number of medical doctors, so you hear a lot more about the clinical staff in this presentation. But as we go down to the discussions, you're going to hear a bit more specific about the public health programs that we are all engaged in our communities, basically. So this is an overview of some health programs and also some health aspects in our continent. Yeah. So we are just going to have an introduction, the brief definitions of the various topics, and then talk about some determinants of health, and then do a little bit more on the sources of disparity that we see in our countries or in our continent. And then we have a little bit of the measures of disparity, which is going to tell us a bit more about the public health, how we are able to measure some of these disparities that we have around. Yeah. So I'll just begin with some quotes from two important people to this Mandela Fellowship and to the struggle. And the first one is from Martin Luther King, and he says that of all the forms of inequality, injustice in health is the most shocking and the most inhumane. It's very, very important to think about, because I think healthcare, as said by Mandela, said health cannot be a question of income. It is a fundamental human right. Very, very important to be able to focus much more on health for the population, make sure everybody has some form of healthcare, and actually it is equal. There is some equity in terms of healthcare. And if you take health disparity, definitely it's quite complex, it's quite multifactorial. And you would want to see that there is some disparity when there is a difference in access to medical treatment, medical care, and also when you have some disparate outcomes in terms of care for the population, or something is being done for the population, but it's being done in different ways, where the outcomes expected are quite different. So it's very important to focus, because there's so much attention on health disparities and health gaps right now from physicians and health policy aspects, because it's the future. We want healthcare to be a fundamental human right, and healthcare that is quite equitable to the population. Yeah, so some few definitions. So health, as described by the WHO, is a state of complete physical, mental, and social well-being, and not just the absence of diseases. Healthcare is the prevention, treatment, and management of illnesses and the preservation of mental and physical well-being, and services offered by the medical and allied health professions, just healthcare. And disparity, the most important thing we should know here is, because the moment there is some form of inequality in healthcare, the moment there is some form of difference, some form of discrepancy in terms of what you give out to a population, maybe somebody gets something while somebody somewhere is not getting the same thing, that is some disparity that we're going to talk about. So health disparities is talking about the differences in health outcomes that are closely linked to social, economic, and environmental disadvantage, and are often driven by the social conditions in which humans or individuals live, learn, work, and play. So some few determinants of health that we talk about. Behavior is very, very important. Definitely, if we're able to know what the determinants of health is, we can be able to drive our public health programs towards this determinants, and that can actually give us some equitable form distribution, also public health programs. So we just need to understand what determines healthcare or health in the environment. And the most important one, or the first one, is behavior. Behavior is quite crucial, because the way people behave, if you come to Africa, you come to Ghana, the way people behave determines a lot what they present to the clinic with. The behavior of people are warned not to smoke, not to drink alcohol. If they engage in that, definitely there should be some consequences, and that definitely presents in the way their health outcomes are. Yes, and it's something that we need to look at if we want to put in public health programs in terms of trying to curtail or stop some of the behaviors that is going to lead people to get diseases. Yeah, the physical environment is also important. Access to clean water, access to a place for defecation. When you go to a place like Ghana, open defecation is very, very common, where people are just doing the stuff just by the beach or close to their houses, or not having quite a decent place. And definitely this leads to a lot of waterborne illnesses, where they present to the clinic all the time with diarrhea and other illnesses. So it's very important to look at the physical environment of the human being, because it's a good determinant of healthcare. The social environment is also very, very important, because the status of the person, or the status, the economic status and all that also determine the kind of the health outcomes somebody is going to have, definitely. Genetics, basically, we know genetics has a crucial role in determination of disease, because we know some diseases run through families or run through generations. And these are things that we need to look at. And if there's anything we need to do in terms of putting programs that's going to identify these people to make sure they have good health outcomes, is very, very important. And then the last part we'll talk about is medical care. Medical care, availability of medical care, access to medical care, and then also the infrastructure is very, very important. That is something that is lacking in Africa. So it makes access to healthcare very difficult for a good number of populations, which is showing that there's so much gaps in healthcare and disparities because the access to the infrastructure is not available, which is quite important. Yeah. All right, so I'll leave the next few slides for Dr. Piva to take over and then complete that for us. Sure.
Yeah, thank you, Cornelius, for the
Your
presentation.
time changing. To keep track of your time, let's give another 10 minutes of presenting and move into a discussion. Piva.
Okay, yes, okay. So as Cornelius rightfully placed it, those health determinants are all the same or they are similar in low and middle income countries, especially countries in Africa. And we have gaps in most of the building blocks that can be used in building a health system. And one of the major building blocks in building a health system is finance, the health system financing. Most of the African countries have limited funding allocation towards health. And this is a serious gap in implementation when it comes to the public health sector. And you find out that some of the countries, or most of the African countries, their payment mechanism for health system, they say is free. They offer free of charge health services, but you find out that the burden is turned towards the population because they have to buy their own drugs outside. They don't have drugs, they have to buy basic equipment for the nurses or for people to be able to attend to them. So that is affecting the public health system. And the insurance scheme, in countries like Africa, you don't have a mandatory insurance scheme for people to be able to access health easily. So you find out that only expats will have insurance schemes, which make the health delivery system to be inequitable. So that's a huge gap. Can you proceed to the next? So another building block is the human resource. You need expertise and expertise to be able to provide efficiency and effectiveness. And you lack that in most of the African countries. You have limited staff. You find out that even during the crisis, during the pandemic, you will see security guards taking temperature and trying to do triage because the lack of knowledge of these people, they allow people to pass. This has a huge gap in the health system. And these people are not supervised. There is poor supervision. Those are all gaps in the health system when it comes to human resource capacity. Can you proceed, Cornelius? Next. Yes, so the service deliverable. Now, you find out that health workers in the public health system are complaining because they lack motivation with incentive. It does not commensurate with their services provided. And even in facilities like you have family planning services are not provided in certain communities, which is a serious setback for reproductive health in communities. And you find out that these people are not having access, they are not making use of it because it's not available. It's not that they don't want to use it, but because it's not available. That's a serious gap. Next. Cornelius?
Yeah, next.
Yeah.
I don't know why it's not going. Sorry. I'll just stop the sharing and then I'll share again.
Okay, so while he's trying to do it, I could still be talking on the services. And you have other services like nutritional programs. These programs are
ready now.
located in the urban area. Yeah,
it's ready now,
yeah.
Dr. Piva.
Yes, okay. So another gap you have is medicine. As I said, in the human resource, in service delivery where they have free services, but now they don't have medicine. Once there's no medications in facilities, it becomes a serious concern, a serious problem. Now, only those who can really afford to get out of the country to order those medications will benefit. So that's inequality, because those who cannot afford cannot have access to those medications because they are not available. There is readily technologies to be used, like CT scans, like diagnostic materials, like the TB program, Gene Experts. It's not available. Those are gaps in the public health setting. If you want to look at holistic, the population health, you cannot have those technologies and you cannot be able to deliver equity health services to all. Lack of tools and technology are not available. It reduces motivation and it reduces proficiency. Can you proceed? Next. Cornelius?
Yes, I don't know, it gets stuck. Sorry.
Oh.
I don't know why that keeps on happening. All right, I'll go ahead again.
Yeah, can you go back? Go down.
Yes. Okay. Yes, next one. You have it?
Yes, so information, this is another important one, gaps that we have. You have poor health information system. In most of the African countries, they are very poor in producing data. And now there is no way to track the systems to know how services are being utilized, which is very important in planning process in the public health environment. Once you don't have those information, you don't know where those services are needed, you don't know where services are most needed, that does not help the system, because you don't know where you need to carry certain services. And we're in the midst of limited resources, you need to know where to allocate your resources, where it's needed to have equitable distribution of the health resources, or else you will carry facilities to places that is not needed. You will carry bucket to places that is not needed. You will carry drugs to places that is not needed. So you have to have good information system, and the human resource distribution, you don't have information on it. You don't have accountability of how many nurses you have in the facility. You don't have accountability of how many paramedics, and you don't know, you will not be able to get the efficiency and the effectiveness from that area, the health outcome. So those are all gaps that we have in the public health sector in Africa. And these gaps, these disparities are similar in almost every African country. Cornelius?
Are we done? Oh, are you sharing still? Just leave it on the screen and just go down, tap on the boxes. Don't do, yeah, just scroll down.
Yes.
And just select the slides.
Yeah. So, and the next slide will be about governance. Governance is one of serious health disparity in the African countries. When we talk about governance, we're talking about the leadership, the policies, health policies, and approaches, decision makings. Decision comes from the top. The ministries, they make the decisions and pass it down towards the rural area. So it's like a top-down approach where the ministries, the central government or the central ministries make the decision and they bring it down to the peripheral sectors, and they are forced to accept it. And once they are not willing to work with it, it will not go through. It won't be effective. It won't be efficient. And corruption is one of the things that we have been fighting. It's our #1 enemy in Africa, and we have been fighting it. And that's one of the disparities. That's one of the health gaps in Africa. So the next one, Cornelius will speak on it.
Yeah, probably just finish this, the last slide. So probably just about a minute, we should be done. Basically, just some ways that we are able to look at, the measures of disparity in our environment. So the prevention quality, it's very important to be able to know whether the preventative care that we have is working. Because at the end of the day, a lot of the public health programs that we should be able to look at how we can be able to increase preventative care. So indicators like ambulatory services and also some sensitive conditions, how are we able to pick this up quite early? How are we able to make sure that the community is devoid of some of this. Also the vital statistics, which is very important, because if you come to Africa, it's very difficult to get data. And this data is about birth and death. In Ghana, when a child is born, it takes so many years before you can get the record on the child. Some places you have to pay money before you can even have a birth certificate for a child, because we don't have social workers in these hospitals or people who are supposed to take this data. These are things that we need, importantly, to be able to make decisions or to make plans for the health of the population, but we don't have. And so birth and death registry is something that is non-existent in our environment. Also access to healthcare, as Dr. Piva spoke about insurance, and also geographically, you can see that some communities are basically torn away from the main city because of the poor roads, and it is not connected to any source of healthcare. And these are people that have to be rigged out to. If you come to places like Ghana, we have some dwarf islands that's going to take you 6 to 12 hours to get a boat ride to get there. These are people who have no access to healthcare. And it's very important that we are able to look at how often these things are seen in the environment. The demographic, definitely, the more people that reach out, the more there is a difference or there's a gap between rich people and poor people, definitely there's going to be a huge gap in healthcare delivery. Definitely, as long as some population is getting richer and some are going poorer, definitely there's going to be health outcome. Also clinical indicators like comorbidities. Now we're having a whole transition in Africa where we are seeing a lot more people coming out with heart conditions. We didn't used to be that. Non-communicable disease didn't used to be something we used to fight with, but it is increasing every day. People in the rural areas are dying from strokes, dying from heart conditions, which is not something we used to see. So definitely these are measures that we can be able to see how much gap or how much disparity that we have in our environment. Right. Thank you very much then. Be available for any discussion or any question.
So let's end the sharing and return to the gallery.
Yes. So stop sharing. Yes.
Thank you. Wonderful presentation. Lots of information. So to recap, I was frantically taking notes. So it seems as if there are 5 different areas where a lot of the health disparities and health concerns kind of fall through. The first one is prevention. How do we prevent people from acquiring all kinds of diseases and illnesses and so forth? The second one that you guys presented was on data, having enough data to track who has what and who's registered for what. So data, health data system is an issue. Infrastructure in terms of even the whole medical system, how it's organized, who have access to medication, who have access to the technology and the tools. So the medical infrastructure is another issue. The fourth issue that you talked about as resources, hospitals not having enough resources to provide the services that people need. And finally, access. Who has access? There's no insurance system in Africa, but there's also issues of access. Those who are rich and who can fly themselves out of the country to come to the United States or Europe and get the healthcare they need. Those are the ones who have access. So of those 5 issues, I'm going to go back to Ms. Bennett. Ms. Bennett, of those 5 issues that our African friends and fellows have shared, do you find some commonalities of some of those issues that we also have in our own system in the United States?
I mean, definitely. There's so many differences that sort of jump out at you, but I mean, health disparities are so significant where we are. I mean, we have major socioeconomic differences. I mean, everyone is required to have health insurance in Massachusetts and in the United States as a whole, but that doesn't mean that people who have immigrated to this country, who are undocumented, they may not have health insurance, and they can easily be turned away at many not everyone, but they can be turned away at many healthcare facilities. We have, I didn't even mention this, but we have 3 shelters for families experiencing homelessness at the Y, and we have many undocumented people that live with us, and we have a very hard time getting healthcare for them. We also experience, significant racism in our medical world. We have a very hard time giving people equitable care here. So maybe we don't have the geography issues, right? We can probably get to a hospital in 45 minutes, even in the most rural place, but But some of those issues are just so similar to what we see in a very different way.
Interesting. Yes, no, we have similar issues. They are not to the extreme that you see in Africa, but all of these 5 issues, there are isolated communities in the United States, particularly in rural America, where there's problems keeping track of data and and so the issues are somewhat similar, just not to the extremes of. I'm curious to hear from Dorothy. Dorothy, in your particular country, what do you see that you could relate to these 5 major issues that we talked about? Dorothy.
Yes, I'm not a public health professional, but some of the major issues is access to the hospitals. And in rural areas, you find they have even a 2-day trek because there are no roads to access the hospital. And then there's also interference by the African traditional medical practices, where some conditions are accrued to witchcraft. So these people who have these conditions, especially non-communicable conditions like epilepsy, cancer, they might come in late for treatment. And with regards to disability, you find that hospitals that cater specifically to people with disabilities, they're very far away. So people will have to travel for a week or more just to get to the hospital, say for spinal injury. I believe we only have one in Kenya, and it's not a large hospital. So a lot of people that suffer spinal injuries in my country actually develop disabilities because of that. Thank you.
Lots of issues. Bekalu, can you share from your country what's going on in relation to these 5 major issues?
Yeah, thank you, Dr. Solomon. I think, I will start somehow from the goods in terms of public health in Ethiopia. And for the last 30 years plus, Ethiopia followed in terms of its policy, prevention priority policy, health policy. And with that in line, we had this what we call public health extension workers, which they will be based in every village in the rural parts of the country, and they based in a health structure system called health post, which is below health center level. And after that, for certain another larger village, you have health center structure. And then primary hospital will come into picture. So a health post, a health center, and a primary hospital are mainly meant for public health programs. And anything above that, secondary or referral hospital and tertiary teaching hospitals, specialized hospitals are more of for medical care, for treatment. So we have lost a good number of health extension workers, public health experts, as compared to other sister countries, and that are somehow the goods of our public health concept and program in general. But one of the things, for the last 30 years, though, we're following a prevention priority health policy. We end up in a devil burden at the middle of these long years. And that was from actually non-communicable disease, the hypertension, diabetes, as Dorothy was saying, cancer, renal disease, cardiac disease, and including trauma, road traffic accident, and the likes comes into picture. And it makes the country a devil burden between communicable and non-communicable disease. Most of the effort and the attention was towards public health concerns and the prevention, but all of a sudden, the nation was hit by non-communicable disease, and it's a huge burden to the country to date, and there is no really appropriate readiness towards that. In terms of disparity, I believe in our country in Ethiopia, we have also an internal disparity between urban and rural, between educated and less educated, or between literate, illiterate, between different. Ethiopia is an 80+ ethnic country, composed federal country. So even between different regions of the country, will get different extent of treatment based on the behavior of the country, the amount of health professionals in that specific region or from that specific ethnic group. So there is really an internal disparity, besides the disparity being, in a low-income country as compared to the developed country. There is an internal disparity that I can mention in Ethiopia, and we don't have actually such a strong, strong public health structures and also medical care structures. Our hospitals are poor of infrastructure. Human resources are not adequate, especially for specialty services. And the public-private, there is a private institutions in Ethiopia, but for majority of the public, they are not affordable. So most of our public health programs, to really summarize in my country, their focus is toward this child health, maternal health, and somehow for marginalized group of people with disabilities and the likes. But their main fund in terms of finance is not really from the inside, from the country budget. Mainly it's focused on an external fund as a program or as a project. And one of the drawback for such programs is when these programs are phasing out, there is a huge problem to maintain all the care and all the delivery of health services, be it in TB, HIV, malaria, whatsoever. When the program is phasing out, I have witnessed lots of programs collapsed, and there is no proper handovering system to national program. So this is what I can say about the public health disparities in Ethiopia. Thank you, Dr.
Very informative, very interesting, because a lot of time something we don't think about, we fund the programs in Africa, but when the program ends, there's no way to maintain it, and the whole thing collapses. And essentially, it's back to square one. That's interesting. Ashaba, Uganda. What's going on in Uganda in terms of health and health disparities?
Thank you very much, Dr. Jabril. Sorry, Dr. Jabril. Well, when it comes to Uganda, I can speak from what I have experienced through the nonprofit and the community work that I've been doing on ground. And I like always reaching the grassroots communities, because I believe these are the communities that are always forgotten. And recently, through my foundation, I wanted us to go in a different direction a bit because of lockdown. So many young girls were getting pregnant within the lockdown spaces. And most of these girls did not have access to materials that they needed when they reached the hospitals. So most of the girls were dying during delivery. So we thought, what could we do for them? So we were getting mama kits and all of that. But when we reached on ground, I always want to hear the story from their side. And the stories we're listening to, because we expected them, there are government hospitals that are available that have been put in, by the government. But when they reach there, these girls were telling us that when they reach there, they have to pay bribe in order for them to be catered for, which does not make sense because these hospitals should be free. But then at the same time, I try to put myself in both, shoes. When you put yourselves in the shoes of the doctors who are working every morning and they're not being paid by the government, then you understand why now they're asking for that bribe, because they also want to feed their families. So you have people who are pregnant walking over 2 kilometers to reach the hospital, and then they have to wait in an entire line, and then they have to bribe. Already they do not have money, they do not have anything to eat. And then the hospital does not even provide what it's supposed to provide, like gloves, surgical, all the things that are needed for a woman to be able to have a safe delivery. And then there is also victim shaming, when they reach there, they're young and all of that. So it is very sad to see that our health system is lacking in so many ways that even the work we do on ground, girls cannot afford such basic human needs like sanitary pads. And yet these are human needs. If you do not have these human needs, you cannot be able to go through the day or function very well. So you find girls stay within their homes because they cannot afford that. Some governments have been able to levy the tax on sanitary pads. Ours, I don't know how long that is going to take, but these are basic needs everyone should be able to access. And then when you reach in these hospitals, local community hospitals, the sight is very sad because I saw these women who had just given birth and they did not have food. Since morning, you've just given birth, they can't even access food. And even the mattresses where they're sleeping, there is no bed sheets, and giving birth is already traumatic as it is. So if you do not have this help around you, it really goes to show. Here, the town hospitals are okay a bit. And that is why I always look out for rural areas, because everyone forgets the rural areas. And yet they are the people who suffer the most. And they're the ones who try to contribute, to the country's tourism and maybe, agriculture and all of that. So for me, what I saw with Uganda, we are still lacking when it comes to health. It is very, very lacking. And I don't know how long it's going to take for us. But then at the same time, I always think that once in a while when we can step in, and that is why we're in such programs, where the government is not doing their job, we can also come in and step in and help the best way we can. Thank you so much.
Thank you, Ashaba. That was very comprehensive. Last but not least, before we run out of our time, let me go to Patricia. Patricia, can you share with us your perspective on health disparities in your country?
All right, I come from Kenya, same as Dorothy, and I also echo the sentiments of Bekalu. So what has happened in our country, Kenya, over the past 5 years is that we have had a devolution of healthcare with the financing for healthcare services decentralized from the national government to county governments, which are like localized governments. And this has created a lot of disparities in healthcare, depending on the priorities of the individual local county government. So you can find that some areas are doing much better because the local government has prioritized healthcare, and other areas are not doing well because their governments have not prioritized that. And then Bekalu had also mentioned about donor funding. So again, most of our public health programs are funded by external partners, and we are currently seeing a push of having a sustainability plan after the partners leave. And some of the things that, for example, we are seeing on the ground are aspects of dollar matching, where, for example, if Gates Foundation is to give us $1, then the country also has to commit to give $1 towards the same public health program, so that in case the funding goes away, then the country can still be able to sustain the program. And even in terms of program delivery, we are seeing a lot of the human resource part being gotten from employees of the government, such that the donor funding is perhaps not paying salaries, but the people who are working for these programs are government employees, so that again, in case funding goes away, then the government employees can still be integrated into the program and sort of enable it to continue. As a country, again, we have been seeing ever since the devolution a lot of challenges with medical doctors, and we are seeing quite a lot of brain drain from the country as people go out to look for other opportunities. So in a snapshot, other than what Dorothy shared, those are additional features of Kenya.
Okay, very well. No, that's wonderful. Ms. Bennett, what are your thoughts and reaction on all these things you're hearing about what's going on in Africa and all the health disparity issues?
I just think it's so interesting because I read about it and I watch videos on it, but to hear like each of the public health topics that's so important to each of you, Ashaba, the maternal health information was so fascinating and heartbreaking. It's just really interesting to hear. Something I never considered was the lack of data and how long it takes to get a birth certificate and things. I mean, that's my area of interest, so that's what I'm going to focus on. But I think, what an impact a data system, and I think we have terrible data systems for our healthcare data here too, like, nothing communicates, but every single day at 5 o'clock for the past 18 months, my phone has gone off and said 922 new COVID cases in the state yesterday. Like, that level of data is, very taken for granted here. And so, hearing about even just the vital statistics that are missing is so interesting, and something that I think, could have such an impact. I think that's just been so, overall, I'm just so thrilled to hear from all of you. I'm learning so much.
No, I mean, it's insightful because, I mean, if you think of even organizations like the Y, which is a nonprofit, and all these other, nonprofit organizations that are well-meaning in our own country, and we send a lot of stuff to different countries to support. It does some good, but what Dekolu was talking about, once that program ends, the whole thing collapsed. There's no way to sustain a lot of these support services. When there's a disaster, we ship all kinds of stuff, but as soon as the disaster goes away, people who are relying on those services are back to square one. So certainly a lot of things for us to think about. I mean, one of the things that caught my attention is, I didn't hear much about things related to mental health. And mental health in the United States is a huge area. My expertise is in mental health studies and neuroscience. So it's interesting that, like Dorothy was saying, people with mental health issues, it is culturally understood and sometimes interpreted as if they were possessed by some spirit. It has nothing to do with the person's brain, chemical brain, and issues happening. That's a whole nother area of health disparity that I think I find very intriguing, that most of the presenters say very little about in terms of just mental health disparities and support services for counseling and so forth. Any last comments? I know we're a little bit over our time. We have, Cornelius is a medical doctor as well as Piva. So let me give you the last 30 seconds we have. Cornelius, in the last 30 seconds we have, I'm going to ask you to give your last comments, and I'll go to Piva and we'll close.
Yeah, thank you. I mean, I was quite happy that you brought up the issue about mental health. That's something that we have a lot of issues with in terms of, as a country in Ghana, we only have about 2 or 3 psychiatric hospitals in this country, and we only have 4 psychiatrists for a population of 30 million. That's how bad it is. So I work in the communities and I work with people with epilepsy and some other conditions, and it is difficult for them to even just get a month's supply of medications just for them to stay up getting their seizures and all that, because we don't have any mental health professionals that are willing to work in these communities, because they're few, or there's no facility for them to stay in. So mental health is a big issue. We don't have any policy or any rule for that. That's something that we are pushing for. Hopefully we are able to make some roads, because I think the newer doctors, some of them are trying to be trained to be mental health specialists. So I think it's quite big. There's a lot of disparity. There's a lot of health issues in our country, and it will take us a whole lot more to talk about just the issues in Ghana. But mental health is quite dear to me and to a lot of growing healthcare professionals in Ghana. So definitely we hope to see some changes. Thank you.
Thank you, Cornelius. I mean, it's shocking that in a country of 19 million plus people, you only have 4 psychiatrists for the whole nation. That's quite a revelation. Piva, let's go to you for the last 30 seconds before we close. And what are your final thoughts as a medical doctor on all of these issues?
Yeah, and I would agree with you. I think we actually should have included mental health. And the disparities with mental health is so huge that we even forgot that it even exists. There are a lot of cases, mental health related cases, substance abuse. There are a lot of them. And like Liberia, we only have 1 psychiatrist with a population of 4 million. And recently we sent 2 medical doctors to be trained in psychiatry in South Africa. So when they return, we'll be having at least 3 psychiatrists, which is still small. And we have, Liberia, a post-war country, we have had a lot of trauma. So there are a lot of mental health issues around, but the discrepancy is so large and we just can't do much about it because we don't have the expertise. And that has been a huge gap. And this is something that we actually should have mentioned. It's good that you brought it up. And the health system in Liberia is structured in a way that we have discrepancy in or disparities in all the building blocks as I mentioned. And this is something that we try to work on, like the Ebola crisis. I should have spoken about the Ebola crisis in one of the sessions, but it was unfortunate that I couldn't talk about it. We were exposed to the Ebola crisis where we just never knew anything about preventive aspects, basic RPCs. It was due to Ebola that we learned how to wash hands, use gloves. We just used to touch patients without using gloves and social distancing. And I mean, there's just this huge gap that we trying to form a resilient health sector to be able to combat, but there are just so many, and I'm sure it would take a very long time to be able to cover them.
All right. Thank you so much, Peter. Thank you, everyone. Kendall, any last words before we close? We are out of time. Thank you kindly.
No, I could listen to you all share your stories for many hours. So thank you so much for giving me your time.
All right. Thank you, everybody, for a wonderful session. And we appreciate your time. The presentation was great. I will forward to you Ms. Bennett's presentation, the PowerPoint presentation, so you can have it to see. And I would also forward your presentation to her. And I will also, when I do that, I will put you in touch with her. So you all will have emails if you wanted to exchange some information or even, needed some guidance on some things when you return, at the end of this program. Feel free to reach out to Kendall. All right, everybody.
Yes,
thank you so much.
Thank you so much, Dr. Solomon, for this show, and thank you, Kendall, for your presentation. We appreciate it. It was so
Thank you so
educative.
much.
Thank you, everybody. Have a good one.
Thank you.
Thank you so much.
All right, good night.
Bye.
Good night.
Bye.